Hello and welcome dear learners to the NPTEL course on Healthcare Quality Management, Infection Control and Patient Safety. In the part 3 for the standard treatment guidelines, we will be focusing more on implementing these guidelines and the limitations and challenges of the standard treatment guidelines. Formulations and dissemination of these guidelines will be looked upon. When we are trying to talk about implementing the guidelines, we have to develop the evidence-based innovations, and this can help actually with the clinical practical guidelines being a prime example, where you may say that integrating these innovations will help often to face the difficulties which are hindering the intended benefits that you are able to get it. So what the STGs have been able for many years, but there is a limited data confirming that they have successfully altered the professional behaviors of healthcare providers, where you say that the lack of change is frequently observed in prescribing and medication use patterns. So simply distributing the CPGs is not helping and typically insufficient to achieve the substantial changes without a dedicated and comprehensive implementation strategy. So the emphasis is more on implementing the strategies actually, which is very important that you need to focus on. When you are trying to say that there is an implementation which is expected, a significant time lags frequently occurs when the introduction of a new clinical advance and its routine application in practice. Modifying established prescribing habit requires a time, making it essential to consistently reinforce the relevance and importance of the guidelines to practitioners. Consequently, active promotion and educational initiatives are very vital. Training program focused on the standard treatment guideline must also address the specific challenges, reservations and concerns that prescribers may have regarding the application of these guidelines. Limitations and challenges of the SDGs: risk of harm, limitation of evaluation, rapid obsolescence, perception of lost autonomy and misuse of role. With respect to risk of harm, inaccurate or incomplete guidelines, especially those lack reliable evidence, can also cause harm or provide a false sense of security. Limitation of evaluation: providers may limit their patient assessment once a patient seems to be fit with respect to the standard treatment protocol. Rapid obsolescence: carefully developed STGs can quickly become outdated and you need to establish a system for regular and review, which is substantially seen as updated in essential part of time consuming. Perception of lost autonomy: guidelines are sometimes viewed as a cookbook, where you may say with respect to medicine, generating concerns about the loss of professional prescribing autonomy. Misuse of role: STG should reduce unwarranted variation in care, not mandate treatment, allowing clinicians to focus on accurate diagnosis. Acceptance and dialogue: involving experienced clinician in development and engaging in dialogue helps mitigate concerns and increases the likelihood of acceptance and endorsement. Misuse and liability: there are concerns about the potential misuse by an unqualified staff, and it is an issue actually where we may find the hospital or the healthcare organization may face lot of legal liabilities. It must be clarified that guidelines are clinical recommendations and not legal statutes, and primarily they inform care for patient populations. So the misuse and liability are very interlinked actually over here. What are the safety requirements to be followed? The guidelines must clearly include crucial first aid measures and the red flag signs actually to ensure timely and appropriate referral, where you need even to go ahead and think on the specialist resistance. Sometimes uniform standards are often welcomed by primary care staff and must face resistance from the specialist who feel that they should offer distinct treatment. Referral criteria may differ, but the initial treatment choice always depends on the patient's condition and not the prescriber's level. So it is very important to be focusing more on the first line initial treatment versus to the next level of treatment. Hesitations to consult: Some practitioners are uncomfortable looking up to the information in front of the patient, and sometimes they may feel that it is a hesitant to the consultant stating that the patient may question the professional's credibility. The credibility part is one where the patient prescriber is much more concerned about. Clinicians should practice using referral materials, though the role play during the training is one a very important part to be emphasized, and that can help them actually to come up to the hesitation. Skepticism of non-participants. This has to be worked on with the prescribers who are not involved in development. This may distrust the recommendation, especially if they are differ significantly from the current practices, and they may create an issue for this part. These discrepancies must be actively identified and discussed in the training programs where they can discuss on this part also. What is the formulation of the standard treatment guideline? Locally developed state STGs can create with the direct participation of end users. The healthcare providers typically receive greater acceptance. However, creating the entirely new STGs for every level of care from the beginning can result in a significant wastage. The wastage can be time, it can be resources, and expenditure if the process is poorly managed. The difficulties can be encountered. Where you find the difficulties comes from the majorly achieving agreement among the diverse stakeholders that can be complex to manage and sticking to the established deadlines often coming from the change area. Ensuring the text is consistent and then can be hard with multiple contributors who may have varied with levels of expertise. When you find the experience shows that certain aspects such as assessment of evidence, systemic review, and core treatment recommendation can be effectively shared across the different settings. Adapting existing high quality guidelines makes the recommendation both relevant and practical for the specific local context. This adaptation process typically fosters strong acceptance among the clinicians, particularly when the local clinical opinion leaders are actively involved. And you may find maximum involvement of these people needs to be. Engaging the practitioners encourages the actual utilization of the guideline. So you have to seek the engaging the practitioners. Their participation is valuable not only for persuading the doctors who are accustomed to the outdated practices, but to change, that also for helping them distinguish between the treatment that should be given simultaneously versus to those one after the other. So this is a very crucial part to be seen where it comes as a challenge actually most of the time for developing the standard treatment guidelines. Another significant advantage that I would like to highlight over here, that is of this collaborative process, is that it helps prevent the repetition of the known errors. Many times it is one very important that most of the errors can be curtailed with the help of this, and this has been seen as a very significant advantage. With respect to Indian context, what are the difficulties and who have adopted it, we will try to see it over here. In India, 8 different states including New Delhi, Himachal Pradesh, Chhattisgarh, Karnataka and even Maharashtra has successfully adopted, they have developed and they have tailored it from the different levels of care. They have been seen that they have been adopting it from a quite time. Several treatment guidelines such as those produced by the Delhi Society for Promotion of Rational Use of Medicines, that is DSPRUM, have gained widespread credibility and acceptance. These specific guidelines have been adopted and formally adopted by several other Indian states. States like Gujarat, states like Rajasthan, Uttarakhand, Haryana, and in addition to New Delhi. Those states ensure that all these doctors working in the public sector received complimentary copies of the documents, which is very important that they can be benefited with when they receive all these materials. The steps that can be seen for forming a guideline. If you can see the convince a guiding committee where development is being seen at the very first part, where you find that after taking the development of that, you determine how the guideline development committee will be operating at the second position. Then come, is there a suitable guideline available for the use or not, that you need to think, and then if no, they develop a guideline, and if yes, then they adapt that guideline. Adapting is one with the search for a guideline and access guideline quality and adapt the guideline. Where versus if it is not there, then they need to develop a guideline. Identify the key questions, then perform a systematic search for that part and to accomplish it, and select and appraise the quality of the CDs, which is very important. That is the reason we say write guidelines, consult the stakeholders, endorse and pilot guideline and update the guidelines. This can be seen as step 1, step 2, step 3 and step 4. This way you can see that how you can form a standard treatment guideline. These steps are being given to you for understanding and to practice actually when you have to take it as a checkpoints actually for that part. Dissemination of the guidelines. This comes as a very important and the next crucial stage or being seen as a step for integrating a guideline into clinical practice that is called as dissemination, which is the purpose that the guidelines are made. A practical and achievable distribution plan must be established. If resources permit, every prescriber should receive a complementary copy that is called as personal copy, where the distribution plan highlights actually the very important plan that to be dissemination. The guideline should be formally incorporated in both pre-service, that is called as initial training, and the in-service, that is ongoing professional development programs. However, mere distribution alone is not sufficient. It needs to modify the professional behavior of the practitioner, which is a very ultimate and important goal of this guideline. And thereby we can say the dissemination of the guideline will have a purpose with respect to the professional behavior which is expected to be changed. Now we can see what is the multifaceted approach that is required when you try to include all these things into practice. The first and very important is that patient education. How it is done? By informing patient about the recommendations. The second would be endorsement. Securing formal support for recognized clinical opinion leaders and professional organizations, which I find is a very important part where you may see that it is a need of this. Promotion in literature, publishing reviews, articles about the guidelines in professional journals, which should be seen as a very improving or I may say encouraging practice. Curriculum integration, adding the guidelines to the course material in the medical schools, specifically targeting the interns, who are one an important way that you can target and improve their knowledge. These coordinated efforts are essentially to significantly enhance the acceptance and adherence to the guidelines, where I would like to focus more on first the acceptance part and the adherence part actually to these guidelines, which is being seen as a very important. And this all will take the multifaceted approach in a required pattern. Now highlighting towards the quality guidelines. So high quality guidelines are vital tools for promoting rational use of medicine. What is the importance of that? As we find that if developed appropriately, they can considerable potential to enhance the patient outcome, which is the very important purpose that we are focusing on these SDGs. However, most of the time we see that the guidelines require dedicated resources and they should be structured, well-defined development process to be successful. This way we can find that ultimately the purpose will be solved. In summary to this chapter, I would try to focus and state that despite being evidence-based innovation, the clinical practices guidelines and the standard treatment guidelines often face significant difficulties. The difficulties might be first coming in the adoption of that. Many times it is being seen that it is not widely accepted, adopted, and have limited impact on the healthcare providers where they don't try to change actually, or sometimes you may see the medication use behavior is something which is not aligned to this. So you need to focus on working on this with the help of the strategies. So without dedicated implementation strategies, it doesn't really works. Poorly developed, outdated or rigid standard treatment guideline can cause harm, and that's what we are seeing it many places actually. The limit to the comprehensive patient evaluation, it limits to generate concerns about the prescribers about the lost autonomy and legal liability, where you may find the specialist may also resist uniform standards. And there where you need to even encompass actually or understand or discuss with those people actually to see that what is the problem actually that you are not going ahead with the current updates, and why they are more emphasizing on the rigid SDGs that they are following up, or sometimes they may not be following any of this. So active involvement is one which I would try to emphasize more to this problem which I have stated. The experienced clinicians, the local opinion leaders need to be there into the development. Along with clear communication, these guidelines are only clinical recommendations, as being seen that they don't come up with any legal mandates, where we try to emphasize that it is nothing that actually to be legally making them more compulsion. It is for the acceptance part and to improve. It makes actually improves the acceptance, addresses the issues like hesitation, which is very much seen in the newcomers, and actually even to those to consult information or to avoid skepticism about the new practices. While developing these standard treatment guidelines with the end users participation gain more acceptance, and where we find that improvement should be more aligned to this. Creating a new one from the scratch can be insufficient. Adapting the existing high quality guidelines makes them relevant locally, and you need to see that a hospital foster the acceptance and helps preventing the repeating errors. These are the one of the reason actually that many a times this is more connected with the culture that the organization or the hospital is following. Effective dissemination requires a comprehensive distribution plan, including free personal copies for the prescribers, formal incorporation into training. However, distribution alone is insufficient to change behavior, where you find that if you are giving the free copies also to the prescribers and formal incorporation in the training, which is the very first part, and being seen the training as a second part. So, you may see that this can bring a change. Ideally, you are expecting the change, but this alone is insufficient to change the behavior, because they need to think on at a practical basis that how it is possible. Where you may find that lot of issues may comes with the prescribers local needs that need also to be sufficient. Then the question comes of how to enhance an adherence. Enhancement or acceptance and adherence will be increased only because of the multifaceted approach. The multifaceted approach is necessary, which involves the patient of giving education to them, endorsement for the clinical leaders, where we find that it is to be acceptance part to be cared of, promotion in the professional journals, where you will find that it is to be published, and integrating this into the syllabi of the medical curriculum, especially for those interns who can be the focus for this. With this, we come an end to this chapter and the discussion on the standard treatment guidelines for this particular lecture, where you may find that these references will be helping you for generating information or putting up in your team for the use of the standard treatment guidelines. So, thank you for the day.